So thank you guys for having me here. So just some background. By way of explanation, I'm a neurooncologist, so I see primarily patients with brain tumors. I also see patients with neurologic complications of other cancers. So if they have a stroke, or they have neuropathy, or they have other neurologic problems associated with the treatment of their cancer or from their cancer, I'll see them as well. And so, just Rabbi Sklarin asked me to come by and talk today, so I pointed out a couple of issues to him. Number one, I am certainly not an expert in Jewish medical ethics. I think I have what I call experiential credentials in the sense that I deal with these issues on almost a daily basis, and I have a basic familiarity with the halachic and the medical ethics issues. As I said, I've been exposed to relevant cases on a daily basis, and essentially what I guess I do know is when to ask someone or when just to worry if asking the right question is not necessarily possible. And I think another problem with this discussion is, when you learn the halachot of Jewish medical ethics or medical halacha, you realize that a lot of this stuff is case-based. And it's case-based, it's what I call casuistic law, which is basically based on a series of cases, most of which were written about 1,800 years ago. It's a little hard to apply the halacha of somebody who's buried underneath the rubble of a building, which is a case that Gemara talks about, to somebody who's on a ventilator. And when you start to appreciate that it's hard for us to kind of apply the very specific rulings of Chazal to the bread and butter cases that we deal with on a daily basis, you start to understand the scope of the problem that we face when we're trying to practice halacha, medical halacha. Additionally, majority of the patients I treat don't really care what halacha says, which is perfectly reasonable. They're either not religious, they're not Jewish, they're not interested in what a rabbi has to say. And so the question then becomes, what is my responsibility vis-a-vis them and their treatment? Do I have the right or the ability to sort of say, well, this is what I believe? So essentially what I'm going to do today is I'm just going to talk about some cases that I've encountered. I'm going to talk about some relevant issues to these cases. And I'm going to solicit what you guys think, if you're willing to sort of speak up and tell me what you think about these questions. So, just I'll go with the first case. This case is someone I actually saw as a resident, because I did rotate through Sloan Kettering as a resident, but I also was involved in her cases a little bit as a fellow. And it very much struck me, I would say it haunted me actually. So she was a 45-year-old woman. She was very together. She was a high-powered political operative, both in New York and in California. She had a brain tumor called CNS lymphoma, which is a relatively treatable brain tumor. We consider it kind of a curable disease in the sense that if we give people enough chemotherapy, they can go into remission for long periods of time, as opposed to the majority of brain tumors that I treat, which are not really curable, and where the outcomes are much poorer. However, she did not do so well. We treated her a couple of times. She recurred a couple of times over 2 years, basically. Finally, we did what we call salvage therapy, which is backup therapy. We gave her radiation to the entire brain, and now her disease has come back again. So there are other things we can do to her, to her, depending on your perspective. And we discussed those with her. One of the primary option we were recommending was something called high-dose chemotherapy with stem cell transplants. We would give her really high doses of chemotherapy, wipe out her immune system, and then give her back her immune system with the thought that we would be essentially curing or hopefully putting the cancer into remission and saving her from the downside to getting all that chemo. So it's hard to know what the response rate of something like that would be. Probably about 10% of a meaningful response, 10% likelihood of meaningful response in her case. The toxicity, by which I mean side effects, would be very, very terrible for her. She'd be in the hospital. This is someone who was very into her appearance. She was, she didn't want to, she lost her hair from the radiation. It was finally starting to grow back. She didn't want to lose her hair again. She didn't want to be in the hospital. She didn't want to feel lousy. She was someone who was very outgoing, very social, very vibrant. And so I was very surprised when at the end of the, she basically said, enough, I don't want to be treated. I want to go home. We gave her supportive care, pain management, and she died a few months later, not in any pain. She was unconscious for the last 3 days of her life. So I don't know about you, I was actually pretty shocked that she opted for this. And I was thinking to myself, well, should she have pushed harder? I mean, she's a young woman, she's very vibrant. If you knew her, you would have been very shocked by this decision. And so the question is, we have a series of conflicting values here. We have Western medical ethics, which really puts primacy on this notion of autonomy, which basically means it's your body, you have the right to make the decision of whether or not you should get treatment. Which stands to reason, right? It's your body. you should decide. If you don't want treatment, tell the doctors to jump in a lake and go back to do whatever you want to do. Halacha may dispute that, and halacha, there's a debate among medical halacha experts, but the majority of them accept the idea that the notion of autonomy, that your body is your own to decide what you want to do with it, is foreign to Jewish medical ethics. Because at the end of the day, it's not your life, it's God's life, He's given it to you, and you have sort of the, you don't really have the right to throw it away. Just like you can't commit suicide, you can't refuse treatment. So that's kind of a gross kind of view of the subject, but I mean, obviously there are nuances to it. The question is, can you make an argument against very toxic treatment for a patient who's terminal, who doesn't really have a good chance of survival, who has no chance at all theoretically, that's unlikely to succeed? What about if there's pain associated with the treatments? And actually, what it turns out is that a lot of modern-day poskim, not all, there's a debate, but a lot of modern-day poskim, particularly Moshe Feinstein, among others, has posited that if the chances of success are low and the patient is likely considered, is going to likely die, they can refuse treatment that could be life-sustaining for a short period of time. If theoretically there will be pain from the treatment, because we have an obligation as well to treat pain and prevent pain. And theoretically, you could say that though you have the obligation to preserve your life, you also have an obligation, you have no obligation to do so at the cost of severe pain. Now, as you imagine, those are very vague guidelines, and how to apply those guidelines to individual cases is extremely difficult. Some would say case by case. What about psychic pain? What about, this isn't really a painful treatment, but I will be miserable. I don't want to go back in the hospital. Truth be told, I'll tolerate it pretty well, but I'm done. I'm done with this treatment. Get me away, get me out of here. I don't want any more blood tests, I don't want anything else. What is that, how does that affect it? And that's an issue that comes up as well. If someone will be so distressed to the point where they're not willing, they'll literally be, erect just from being treated, from having their wishes disregarded, and you can potentially even, according to some folks, disregard those wishes and not opt for further treatment that's directed at the disease that's not really curable. I seem to be very bad at using the smartphone. Okay, there we go. So just some questions for you. What if she were 85 instead of 45? Would that change anything? What if she had severe cognitive dysfunction, or if she, I had a patient when I was an intern, which also stuck with me. This guy, he was a firefighter. He was injured in a fire. He was intubated by his colleagues, his firefighter colleagues on the scene. It didn't go well. He ended up having severe brain damage. And he was essentially ventilator dependent in what's called a persistent vegetative state for the rest of his life, which turned out to be, with good care, close to 15 years. Wow. His mother took care of him. He was here as a guy. His mother was probably in her 70s or something. He was in his 40s. And he was a guy who really had no, we would say, quality of life in the sense that he didn't interact with anyone. And he developed lymphoma. So my attending doctor was his primary doctor, and he treated this guy with pretty aggressive therapy. And at the time, we were all like, what is this guy doing? What is he, crazy? He's taking this guy, he has no quality of life, he's giving him all this treatment. And really the mother was very insistent. She's like, look, he's my son, this is what he would have wanted. And that's kind of the other side of it. Can we say that his life, where we assume he has no cognitive ability and no ability to interact with the world around him, is worth less than the life of a 45-year-old, very vibrant woman who's, kind of a social butterfly and all that? What is or for that matter, a nuclear physicist? How do we judge these things? And the answer is, halacha may say that there is no difference in terms of the value of these lives. Ethics may have a different answer, and that's sort of an area of conflict. I'm not sure that I have answers for you about this question. I don't, in fact. But these are some of the questions. This is one question that we deal with. And it kind of leads to another interesting case. So this is a case, this is someone I saw last year. 75-year-old guy, he has advanced lung cancer. He was found to have brain and what's called leptomeningeal metastases. So brain metastases are cancer spreading to the brain. Leptomeningeal metastases are cancer spreading to the wrapping around the brain. The brain is kind of bathed in this cerebrospinal fluid. If there are cancer cells in there, then the outcome in those patients is very, very poor. The median survival means the average patient lives about 2 months. Although some patients, even with this cancer, with this specific cancer and this kind of cancer spread, do live longer. I just happened to see a patient yesterday who lived for over a year with this kind of complication. Again, special cases, different individual cases depending on the biology of the tumor. So she had the standard this guy had the standard treatment with whole brain radiation. He's in the middle of his course, and then all of a sudden he develops a stroke. He develops right-sided weakness, kind of a little better, a little worse. not really able to stand, but able to move. He also had some problems with getting too much fluid. He went into some respiratory issues. We had to diurese him out of fluid. And basically, we held his radiation because of the stroke until his neurologic deficits, his weakness, stabilized to the point where he had some weakness. He couldn't really walk, but he was able to communicate, talk to his family. Now he can't go back and forth from home. He needs to get the rest of his radiation in the hospital. So he ended up staying on our service in the hospital. Over this time, he basically developed this progressive depression. He wasn't really interested in food. He wasn't interested in anything. He was sleeping a lot more. He also developed a lot of constipation, which is a big problem for patients with on pain medications, who have cancer in their belly. They can get really obstructed. And so we weren't sure, are his symptoms from his brain disease, or his symptoms from a stroke, or his symptoms from some of the obstruction symptoms from the belly disease. We weren't really sure. It was a little hard to figure out. So basically we sat down with the family. The daughter was actually a medical student. The other daughter was a lawyer, and the wife was primarily Russian speaking, but we were able to talk to her with a translator. And we talked about what we call the goals of care, which is, where are we going from here? What are we trying to accomplish? And so what we ended up coming up with was, look, the cancer-directed therapy is not helping this guy. He's going to do badly. We want to minimize his pain. We want to try to get him home to spend time with his family. And the family was also very concerned about the fact that he wasn't eating, that he seemed down, he wasn't really interacting. So what could we do to help this? So basically, we were all set to send him home with pain medications and what we call hospice service. The family refused to take him home. They said, look, he's not eating, he's confused, he seems to be in some pain. Can you guys help him? So we tried to do various things. To make a long story short, he's getting worse. We don't really know why. And we checked labs on him, and his sodium level in the blood is super high, which can be a cause of confusion. It's usually a sign of dehydration, which is not surprising. This guy's not really taking in food. We weren't giving him fluids. That's not a typical thing to do with patients in this situation. And so theoretically, this is something that's relatively fixable in the short term. You can fix this problem of low sodium, perhaps improve him to his better mental status before he goes home. It would take a little bit of effort, though. You gotta check a lot of blood, you gotta give him some medications, you gotta balance the fluids, the nephrology, the renal doctors got involved. It was a very complex case, and we were debating whether or not to do any of this. And again, remember that none of this would fix his underlying problem, which is that he has cancer that's spread to his brain, and he's dying of that. So the attending physician on service said that, look, aggressive measures in this case, including fluids and food and all that, are not, and checking labs, are against sort of the focus, which is our focus on palliative care, on improving pain. We got to make sure his pain is controlled, but waking him up with all this, with causing all these, painful interventions is not in keeping with what we've decided. So we kept him on a little bit of fluids. We didn't really address the sodium. He died in the hospital about a day later, completely, comatose, not able to wake up. The family was very unhappy. They felt that we didn't do our right by him. We had this question, could we have, this haunts me all the time, could we have done more for this guy? The attending said to me, Sam, this is how these patients die. And that was a very, very striking statement, which I kind of haunts me to this day. Is that true? Is that the case? It may be. So there was a question. Basically, there are points I think to consider here. What is a heroic measure versus what is basic supportive care? Some of the, again, the majority of at least ultra-Orthodox posting in this question say that you have to continue fluids and nutrition because those are natural things. And those are natural things that the body needs as opposed to treatments, and oxygen, which is a very vague thing. I don't know what that means. Does that mean via ventilator, via just a face mask? It's not clear to me what they mean by that. And they say that you have to continue these things even if the patient's in poor condition, as opposed to cancer-directed treatment or disease-directed treatment. What about reversible disease? What about if the patient gets a pneumonia? Do you have to treat the pneumonia with antibiotics? Relatively easily treatable, won't change the underlying course of the patient's disease. What about if the patient needs dialysis? What if they need a ventilator to help them breathe? What if they need CPR? Their heart stops, they need CPR. All of these questions are addressed, none of them, in my opinion, very well, because again, the case law and the actual cases differ very strongly. Sure, what's your question?
Yeah, so would post group say Jews are not, or Orthodox group say they're not allowed to sign the DNR?
So that's a very good question. You have different answers to that question.
What is a DNR?
So a DNR is basically it's an order that when you come to a hospital, the baseline assumption is that if your heart stops, that you need CPR and life-sustaining measures, unless you specifically say that you don't want those taken. it's important to know that for a majority of patients, even in the hospital, the recovery from CPR, patients with an underlying condition like cancer, is extremely, extremely low. Doesn't mean it's negligible, but it's low, and so we tell our patients this. But however, if they don't sign a DNR, we are obliged, I'm sorry? Depending on who talks to them. And if you explain what the process entails and what the likelihood of success in that situation is, they tend to, although sometimes people will revoke it at the last minute. It really kind of depends on the individual case. Depends, CPR is most effective in people who have an irregular heart rhythm from intrinsic heart disease, or they have heart stops related to a blood clot in the lungs, where you can theoretically have something that's treatable in the short term. If they're in multi-organ failure from their underlying cancer, then the likelihood of them recovering from CPR is very low, and it's a very painful procedure. It involves breaking of ribs. It's not a pretty thing to see. Put it that way. I've been in many codes. They're always awful. Sometimes you can bring somebody back and they can have a meaningful life. The majority of times you don't. So to answer your question, I mean, can you not sign it? You probably can, but it depends. There's something called a halachic DNR, which you can consult with a posek about what exactly you let people do. But again, what this comes back to is the question, really Ramos's question in the last case. Well, if it's painful and it's not likely to reverse the underlying cause, then can you say I don't want this painful therapy? And I would say yes. It seems to me at least that you're saying, look, this is painful. If I wake up, if I do survive, I may not be in a state that I want to be in. Don't do this thing to me that is not going to be very helpful. And theoretically will cause me pain and won't cure me of my underlying disease. That's kind of a situation where you could make the case that you shouldn't have to, that you should be able to sign on, you shouldn't have to undergo that. But again, you'll find different poskim very conservative poskim on this question and very reactionary poskim on this question. And I think there's also some understanding issues better than others, the medical issues. And I think it's a question of who you ask and how you ask the question. Just relevant questions to patients that I see. What about anti-seizure medicines? What about steroids? We give patients steroids a lot because it helps with their brain swelling. It doesn't cure them. It can keep them awake for longer. I had a patient who, I'll call this case 2.5. Here's a question for you. You guys learned about what a goses is? Or a goses is basically someone who is nearing death. It's a halachic term, very poorly defined. It's basically, some people define it as someone who's going to die within 72 hours, although nowadays you have different positions on that question because modern medicine can keep such people alive for much longer. Some people say there's no such thing as a goses anymore. Other people say a goses can be someone who can live for months potentially, but the idea behind a goses is someone who probably is going to die, who theoretically should not be, whose life is sort of kind of sputtering out is the way that the host can describe it. And theoretically, you don't need to intervene on that person in an active way, but you shouldn't sort of try to move that person. That's according to the various halachic perspectives on this question. You shouldn't try to do things that are unnecessary because theoretically you could hasten death in that situation. This guy probably fit the category if anyone ever did, and theoretically he was someone who shouldn't, who many sources say should not have been intervened on in, with further cancer-directed therapy, and even, therapies like, some therapies for reversible causes. Again, the issue is very unclear, but, again, this is a category to bear in mind. This is someone who, to my mind, at least fit this category of goses, with the attendant halachic, implications of that. This guy, case 2.5, he's a 45-year-old guy. He was an end-stage brain tumor. That's the bread and butter of what I say, glioblastoma. He's been through, it's a very aggressive tumor. He progressed through 4 or 5 courses of therapy. He was in a hospice, what's called Calvary Hospice, which is a hospice in the Bronx, where basically patients, their pain is taken care of. It's like a hospital, but it focuses not on cancer therapy, but on managing symptoms and keeping people as comfortable as possible. It's a fantastic place. This guy was doing pretty well there. He was, his tumor had left him unable to speak, aphasic. Hemiplegic, unable to move one side of his body, the right side of his body, awake for 3 to 4 hours a day, pretty decent quality of life, not in much pain. He does have a history of active seizures related to his brain tumor. His wife, the doctors there are very good at managing those symptoms, but the wife called me up. I had a good, I'd seen him in clinic 4 or 5 times, I had a good relationship with the wife. She called me up, and she said, should we continue his IV fluids? Should we continue his anti-seizure medicine? Should we continue his high-dose steroids that he was on? Now, quite frankly, none of those things were, you could talk about each of them individually, but the steroids probably maybe keeping him alive for a couple of days longer, maybe keeping him awake a little longer, hard to say, maybe preventing some headache. So I said, it doesn't look, quite frankly, the difference is not clear, but I said, sure, I don't think there's a downside to it, and I think the upside to it is that it may provide him some pain. There are other ways to manage pain, but I thought that withdrawing those potentially could precipitate death, and so I told her not to. IV fluids, there's no evidence, interesting, when they've looked, there's no evidence that people who have fluids people with end-stage cancer who have their nutrition or hydration withdrawn die any faster. In fact, sometimes they may survive a little longer depending on, and that's true for, aggressive treatments in general. If you focus on symptoms-based care for these patients as opposed to cancer-based care, you can actually keep them alive for longer. They die no faster, and in fact, they may live longer, according to some studies. So, IV fluids, if you talk to some folks, they would say absolutely. Others would say no. In his case, I said, look, his wife was really upset about withdrawing fluid. She said, well, he's going to be thirsty, he's going to, be dehydrated. It wasn't really clear to me that that would be the case, but I said, look, continue them. I don't think there's a downside to it. His anti-seizure medicines, I said, absolutely continue them. Again, it's a treatable, potentially a preventable/treatable condition. Seizures are uncomfortable, and so our general approach is continue those. But again, you start to see how it's very murky as to how you address these questions, because the case law really never anticipated the variety of medical interventions that we can do today. And so you start to realize that you need to apply these, these cases either very liberally, or in certain cases, you may need to kind of, improvise, if you will, for some of these questions. But I think, at least these two cases definitely demonstrated that. I could go on, but I think, do we have another?
3 more minutes. You have 3 more minutes.
All right, let me, this is a relatively...
And maybe we'll stay for another 2 more minutes, is that okay?
I can answer questions too. This is a relatively long case, and I'm not sure that it's that, there isn't that much utility to it. There's one more case I was going to do, which I think was an interesting case, which I'm now trying to get.
A long case.
All right. So this is a case, we see this from time to time. Pregnant woman, mid-30s, second trimester of pregnancy, 18 weeks in or so, has a seizure. She gets admitted to the hospital. She's found to have a very large frontal brain tumor in the front part of the brain.
This is the case we had. We had this case.
You had this case.
Eliezer has this case.
So there's a lot of different positions on this.
All right,
case.
here we go.
So the tumor was actually turned out to be something looked like on the imaging, although that's not absolutely clear. You can't tell these from the imaging all the time. It looked like what's called an oligodendroglioma, which is basically a relatively treatable brain tumor compared to the other tumors that we see. Essentially, it usually is more chemoresponsive compared to its cousin, the glioblastoma, which is a much more aggressive tumor that usually doesn't respond very well. So the options, what are the options? So we can't treat, we can't necessarily treat, although that's not clear as you'll see, we can't necessarily treat her through the pregnancy. So what are the options? Can she abort the fetus and then get treated? Can she try surgery followed by radiation and chemotherapy, or chemo alone, depending on what the pathology shows, while she's pregnant, all the while? Can she manage her symptoms, sort of, kind of string her along until the OBGYN feels that it's until the OBGYN feels that it's okay to deliver a baby, probably about 32 weeks, 30 to 32 weeks, depending on depending on the OB. But again, it depends on the individual case and how she's doing. So, what about waiting it out? What are the issues? So theoretically, she could have a lot of seizures. Seizures are very hard to control in patients with this kind of brain tumor. Sometimes they need multiple medications. Many of the medications are what we call teratogenic, which means they can cause problems with the kid, with the baby. Uncontrolled seizures are very dangerous in these patients. So theoretically, the risk of seizures in this lady was actually significant, and that could be fatal, both to her and to the fetus. Steroids are usually how we manage these patients up front. Steroids can be beneficial in the short term, but dangerous in the long term to the fetus. There is no real downside to the mother. The tumor will probably grow if you let it stay, depending on how aggressive the tumor it is. There may be higher risks associated to the mother because of the pregnancy. People who are pregnant have more of a risk of blood clots. People with brain tumors have more of a risk of blood clots. If you're pregnant and a brain tumor, you have a high risk of blood clots. You could have a hemorrhage into the tumor because your blood volume when you're pregnant is increased. So what about surgery treatment while the woman's pregnant? So there's a possible risk to the fetus from surgery. Radiation, it's probably okay to radiate people who are pregnant if you're radiating the brain, because studies have shown, even though there's this knee-jerk reaction that you can't do that, You probably can. I mean, studies have shown that proper shielding of the abdomen and far away from the abdomen, you probably, at this stage in the pregnancy, you probably can do safely. The organs are already formed, the kids do okay. What about chemo? Chemo is probably more real, but again, we don't know. We're not really sure. There's studies that have shown, aggressive tumors, aggressive cancers like leukemia. They've treated patients who are pregnant. Some babies have done well, some haven't. It really kind of depends. So could be safe, could not. We're not really sure. So basically, so here are the questions: is the woman allowed to abort? If so, why? So what are the issues surrounding abortion? You guys discussed that. It sounds like so. Based on the Gemara and Sanhedrin at the very least, but there's other sources as well. Is the baby eroded? Is the baby considered someone who's coming to kill the mother? So that's probably, I would say, the most widely accepted view, but not across the board. Let me ask you a question though. What if the baby is not the source of the danger? It's one thing if the mother has a condition where the baby is directly responsible for the mother's ill health. In this case, I would think at least, thinking it through, that in most ways of thinking, perhaps except for the blood clot issue, the baby itself is almost ancillary. The baby's preventing treatment, but not necessarily endangering the mother's life per se. I'm not sure what the answer to that question is, but I'm not sure that it's as clear cut as people make it. There's a famous line in the Gemara. The Gemara says, "My plus is to do much a day, so much day." It basically means, if someone tells you kill someone, or I'll kill you, you have to submit to be killed, right? That's the classic case of the Gemara, because who's to say that your blood is redder than his, i.e., why is your life more valuable than his? So theoretically, that only applies to another living person, but not necessarily to a fetus. So you could make that case that if there's two risks of death competing, the death of the fetus is less problematic than the death of the mother. Rashi actually Sanhedrin says that these rather strikingly metaphysical statement for Rashi. Rashi says that these embryos don't have a neshama. So not sure what to make of that, but maybe you can abort based on that ground. What about is there a biblical prohibition against abortion? Not everybody accepts that. Some people say it's only a derabbanan. Perhaps the life of the mother could certainly overweigh a rabbinic prohibition. What if we said that the baby is a risk to her life? Is she compelled to abort the baby? Can she say, I don't want to have an abortion, I want to go ahead and sort of wait it out, deliver my baby, and then get treated, if it's a risk to her life? Is she allowed to say that? The answer, I think, looking through some of the posting seems to be yes, but again, there's no consensus on this issue, which is, I hope, a theme that you're getting. Basically, the outcome, to make a long story short, she ended up opting against abortion. She managed her for the anti-seizure medications, and she did well. We did a C-section and took her to the OR for a craniotomy to remove the bulk of the tumor. We were lucky; it was an oligodendroglioma with positive genetic features that made her amenable to treatment, and she's doing well. The baby's doing well, and the story had a happy ending, but just as easily could have gone the other way in a number of ways. And so, I guess what I'm trying to point out is that these categories are very useful to think of, but again, they have to be applied in a reasoned and informed way, I would say. And if you have a rabbi who's making a decision without the appropriate medical knowledge, you're not really necessarily going to make the best decision. If you have a doctor who's weighing in on a question without the appropriate halachic perspective, then you may not get the best halachic answer. But I think you need to consider both of those entities. Thank you.